Hi, everyone. My name is Michela Tomlinson, and I'm a third-year pre-medical major at Cal Poly San Luis Obispo. I'm about to graduate. I'm a biological sciences major. Thank you for joining us today. We'll be talking about language barriers and innovative solutions with Canopy Innovation. Today we'll have Bill Tan speaking for about 45 minutes, and then we'll have a 15-minute question and answer period. Feel free to let us know if you have any questions throughout. With that, off to you, Bill.
Thank you for joining us. Thank you, Michela, for the invitation. So with me today are actually three of my colleagues. I'm Bill Tan, the founder and CEO. And I have Anniken, who is our Director for Research and Development. Anniken's team implements our NIH-funded projects to evaluate our products in the field. Kevin, who is our product manager, he translates between our researchers and our engineers to bring the products to fruition. Also with us here is Bruna, who is in charge of our content strategies and also our growth strategy, and she supports our user base to achieve their goals. So I'm going to hand the mic over to Bruna for a quick housekeeping item.
Hey everyone, so before we all start, I'd like to let you know that participants are in listen-only mode and that we will have time for questions at the end of the webinar. To send us your questions, click on the chat and Q&A icons on the top right of the screen. And also, just a reminder that this presentation is being recorded and will be available for you to download or review it after we finish.
Great. Just to make sure, is our audio still coming through okay?
Yes.
Are you able to hear us?
Yes,
okay, great. Thank you.
Yes.
Okay, very good. Okay. So a quick overview of some of the topics we'll be touching on today. What are the key challenges that comprise the language barrier? What are some of the innovative solutions that are currently available and are being worked on and will become available on the horizon? And equally importantly, what are some of the things that we can do both as individuals and as organizations to bring about change and improve the quality of care and access to care for patients who have limited English proficiency? So let me give you a quick overview of Canopy Innovations. We are a digital health company located in New York City, and we're very pleased to have had an ongoing partnership with AMSA to bring about innovative technologies to the AMSA membership. As the founder, I have started Canopy based on my personal experience accompanying my family members to their medical appointments. And being the one who is more fluent in English, I often translate for them, and I have witnessed firsthand the frustration that was experienced on both sides of the language divide. For immigrant families to pull the kids out of school to serve as an interpreter is especially gut-wrenching. As you know, a lot of them rest so much hope on their next generation to assimilate and to thrive, but having to take them out of a school day to interpret goes in direct contradiction to that desire to keep the kids in school. And we once did a very rough calculation, back-of-the-envelope type of map, and we figured that there might be about 120 school days that are missed in New York City alone, just public schools, because children are being pulled out from the classrooms to serve as interpreters for their family members, either in a medical setting or in a social service setting. So we started Canopy to develop better technologies to bridge the gap, and along the way we got the support and the attention from the NIH to bring our research and development efforts to a whole new level. So when it comes to self-introduction, I'm often reminded of a famous quote from Golda Meir, the former Prime Minister of Israel, who said to a visiting dignitary that, "Sir, don't be so humble, you're not that great." So if you would allow me, I'll just set aside our modesty for a moment here and share with you some of the things that Canopy has done. So as I mentioned, we are a recipient of several small business innovation research awards from the NIH. Some of them are from the National Institute for Minority Health and Health Disparities to develop Canopy and several other products. We have been a winner of Health 2.0 pilots to bring digital health innovators and large healthcare systems together to pilot test innovative technologies on the front line and in real-world settings. Canopy Learn, which is our medical Spanish training platform, is now #1 in the U.S., is the most widely used training platform for learning a medical language. We have another project called Canopy Speak. It is an app that features the largest corpus of pre-translated medical phrases. It's currently available in 14 languages and about 4,000 phrases and counting. So that gives you a flavor of some of the things that we do and how we approach the language barrier. I'm now going to hand the mic over to Anniken to give us a sense of the evidence base on the language barrier.
Thank you, Bill. So the ability to speak with your patients is key in providing high-quality care, and the capability to communicate with patients in more languages than English is now becoming increasingly critical. In the U.S., the limited English proficiency, or LEP population, has surpassed 26 million individuals, and they represent more than 350 languages and dialects. This means that, on average, about 1 in 8 of the patients that you encounter in your work will have limitations in their ability to communicate with you in English. In the New York metro area alone, where we are located, over 1/3 of the population speaks a language that's not English at home, and that's almost 200 different languages spoken. The language barrier we're facing in healthcare provision has a substantial adverse impact on both patients and providers. While the healthcare system is difficult to navigate even for native English speakers, LEP individuals are often more vulnerable. They're often immigrants who are uninsured, or they lack the cultural familiarity to effectively seek social services and healthcare resources. So not surprisingly, compared to English-speaking patients, LEP individuals report less satisfaction with the healthcare services, they have higher readmission rates, and they're less likely to attend follow-up appointments. While these are highly unfortunate implications, there are also examples where the consequences of miscommunication endangers patients' lives. One of the most well-known cases illustrating the potential tragic or fatal consequences of misinterpretation is that of Willie Rodriguez, who was an 18-year-old baseball player who got a severe headache and then collapsed. He was taken to the hospital by his mother and sister, who were trying to communicate to the emergency room staff that he was intoxicado. While intoxicado was a term referring to feeling sick after something you ate, the physician mistakenly interpreted it to mean intoxicated and therefore treated him for a drug overdose. Tragically, Willie's headache was due to a brain hemorrhage that continued to bleed for 2 more days and resulted in quadriplegia for Willie and also a $71 million malpractice settlement for the hospital. In clinical settings, accompanying family members are often relied on as interpreters. This was also something we saw in one of the Canopy pilots we did, where 87% of the emergency medicine residents that we surveyed reported that they frequently rely on family members or other ad hoc interpreters when they work with LEP patients. However, this mode of translation has often led to negative repercussions, both for the patient and also for the interpreting family members. There's also several examples where underage family members are used as interpreters. One is from a New York City hospital where a 7-year-old boy had to interpret for his Spanish-speaking uncle, whose toe had been crushed in a construction site accident a few weeks earlier. This was his uncle's 3rd trip to the ER for the same injury, but as he was unable to describe his symptoms effectively in English, the doctors had dismissed him. At this point, his toe had developed gangrene and had to be amputated. The doctor wanted the boy to communicate to his uncle that he needed an emergency amputation, but the boy didn't fully understand, and when relaying the message to his uncle, he said, "I'm not sure if they said foot or if they said toe." Another case describes how a 15-year-old boy was asked by a physician to explain to his aunt that she had ovarian cancer. So these are clearly situations that children should never be put in. With a vast shortage of medical interpreters and a lack of appropriate language assistance services, only a small fraction of LEP individuals actually receive appropriate language support to communicate in a medical setting. Live interpretation, which is considered the best type of language service, is expensive, and many providers report being discouraged from using over-the-phone interpretation because their facilities just unable to afford it. Current solutions are also often built on outdated technology, such as shared phone headsets or even pagers. Providers also commonly describe language services as uncoordinated or convoluted to use, and they report receiving interpretation services that are of low quality. And to illustrate some of these challenges, we'll show you a short video. It's a clip from the HBO show Getting On. And while this clip is clearly dramatized for a TV show, it still does a good job of demonstrating some of the shortcomings of the available services that we have.
បងនៅទីនេះបងចង់ដឹងរឿងខ្ញុំទេហើយដើម្បីបញ្ជាក់ពីបំរើឆ្វេងស្ដាំខ្ញុំមិនអាចខ្ញុំធ្លាប់ដើរនៅ Extended care first floor គូខ្ញុំខ្លួន Okay Don yeah it's the language line to translate Jesus thank God okay when can it come down okay They said they can't send someone until tomorrow. Just cannot wait. We need to take care of this right now. Do not let them off the phone. See if maybe we can just tell them what she's saying, and then it can translate it for us. We're going to try to tell you what she's saying. Okay. Mahoba Chinyam. Mahoba Chinyam. Mahoba Chinyam. Mahoba Chinyam. He says that doesn't mean anything. Nothing. Something Chimnakin. Some Chimnakin. You got to go up. Chimnakin. He said that doesn't mean anything either. ញ៉ាំមិនបានផងខ្ញុំញ៉ាំអត់បានម្ហូបនេះខ្ញុំញ៉ាំអត់កើតខ្ញុំអត់ចូលចិត្តម្ហូបហ្នឹងទេខ្ញុំអត់ចូលចិត្តម្ហូបហ្នឹងទេម្ហូបនេះអត់ឆ្ងាញ់ខ្ញុំអត់ចង់បានម្ហូបនេះខ្ញុំអត់ចង់នៅជាទីខ្ញុំទ្រាំមិនបានខ្ញុំមកឆាយទ្រាំមានបានខ្ញុំមកឆាយទ្រាំមានបានខ្ញុំមកឆាយទ្រាំមានបានទ្រាំមកប៉ែងខ្ញុំមិនចាន់ទ្រាំមកឆាយទ្រាំមកប៉ែងខ្ញុំមិនចាន់ទ្រាំបំឆាយChucky Chuck. How much time for me buying? Tell me buying. Because that doesn't mean anything either. Okay, you know what? Put it on speakerphone. Put it on speakerphone, and then they can hear her directly. I think that's worth it. How do I do that? Press hold and then intercom and then line. What then what? Whatever line. How do I know which one? Because it's blinking. You'll see it blinking. What blink? It's flashing in front of you, Denise. Can you see it flashing? Hold it back. I don't know how to work this. You know what? Hold it up. Hold the phone up. Hold it out as far as you can, and then they'll hear what she's saying. And tell them it's something Chinese. We think it's something Chinese. That's a good one. That's got to be something. Did you get that? Good. She says, I can't stand this. I wish I was dead. Please kill me. It's Khmer. She's Cambodian. Cambodian. I knew it was something like that. Hey, note it in the file, please. Thank you. What's your name?
So the video that we just watched also shows how stressful the language barrier can be for the providers. It's nearly impossible for them to provide safe and effective care without adequate language support and without the appropriate tools and systems. And also, in one study, as much as 78% of physicians have reported experiencing workplace stress as a direct result of providing care to LEP patients. This was also reflected in the results from one of our pilots. We surveyed residents about their experiences working with LEP patients, and 30% of them reported feeling powerless when dealing with LEP patients. 43% of them said that they had to do more guesswork. 77% said that they felt frustrated, and half of them reported that they ended up doing more testing and omitting conversations. So to sum up, the challenges that we're dealing with are complex and they're severe, and they impact a large and fastly growing population. And with that, I'll hand it over to Kevin, who's going to share some of the solutions that we've worked on to address these challenges.
Thank you, Anniken, and hello, everybody. My name is Kevin, and I will be going over the innovative solutions that Canopy provides to tackle the patient-provider miscommunication problem. The first solution I will go over is Canopy Learn. Canopy Learn is the most comprehensive online language course for healthcare. It contains a research-validated pedagogy with a 40-hour curriculum spread over 36 lessons. Canopy Learn is appropriate for beginners and heritage Spanish speakers, as it is a language learning platform that prepares its users to speak Spanish in a medical context. Some of the unique features that Canopy Learn offers is its medical telenovelas drama series, interactive speaking exercises, and explanations of cultural concepts. Let's take a look into one lesson of the course to get a better sense of some of these unique features. As mentioned earlier, Canopy Learn has 3 levels. Let's take a look at level 2. As you can see, the lessons are organized on the left-hand side. Everything is in a medical context. We'll take a look at something from pharmacy and medicine. The course's self-directed exercises guide students to learn both medical Spanish and also cultural competency. Each lesson will be introduced by the tutor to highlight the key concepts that will be taught throughout the lesson.
Hola, good to see you again. This session will focus on medication, and we'll start by learning vocabulary for different types of drugs. Next, you'll learn how to use the present perfect tense to discuss events that have happened in the past. Then we'll revisit medication and go over words you'll need to give proper dosage instructions and warnings about side effects.
Great. So now that we have understanding of what we'll learn this lesson, let us jump into one of the exercises I mentioned earlier. Here is an example of the role play exercise I mentioned. These exercises allow you to listen to how a phrase is supposed to be said by a provider. Okay, one phrase.
Hola, señorita Torres. ¿Cómo está hoy?
Then it allows you to record yourself saying that same phrase into the program and compare how that phrase is supposed to be said versus how you are saying it. The microphone. Hola, señorita Torres. ¿Cómo está hoy? The microphone. Hola, señorita Torres. ¿Cómo está hoy? Great. In addition to learning medical Spanish, you will also learn about areas of cultural competency. Here's one example.
We commonly exchange the words medicine and drug in English. We routinely refer to drug trials, drug companies, and drug interactions when we discuss medicine. Although they are interchangeable terms in English, they have very separate meanings in Spanish. Las medicinas are purchased in a farmacia from a farmacéutico and can be over-the-counter or recetadas, while las drogas are purchased from a traficante de drogas and are illegal. When speaking Spanish, be sure not to confuse the two since they have very different meanings.
Very good to know. Canopy Learn also provides a telenovela drama series that students can watch. The telenovela puts the lessons of vocabulary, grammar, and cultural competency into context. Here's a short snippet.
Tenemos que hacerle unas preguntas para determinar qué tipo de medicamentos le vamos a necesitar. ¿Está bien, doctor? Muy bien. ¿Tiene problemas cardíacos? No. ¿Es alérgica? A las berenjenas.
¿Qué es lo que le causan las berenjenas?
¿Me sale?
That was a short taste of the telenovela. It gets very juicy. As you watch the telenovela, you can do exercises based on them. You receive a patient dossier, you read patient's diagnosis and treatment, and you answer true or false questions based on the episode you just watched. Here are the true and false questions that you answer. So the course also contains a plethora of other types of research-validated exercises for students to better learn medical Spanish. This was just one example of one lesson in the entire Canopy Learn course. The course is continually being developed to expand the Canopy Learn offering. The upcoming release will include mobile access to the course in two ways: the ability to take the full Canopy Learn course on mobile devices, and as well as taking exercises on the go on a native mobile application. On the administrator side, we are expanding the current capabilities of capturing and analyzing data to better assess the language acquisition of Canopy users. This will help us make better decisions on which aspects of the course are the most effective. We also provide a free iOS and Android reference app that contains over 4,000 medical phrases that have been translated into 15 different languages and dialects. This app is great for when you want to communicate with your limited English-speaking patients in a pinch. The app also allows users to have one-touch access to live interpreters without needing to fumble around looking for interpreter phone numbers and even access codes. Recently, Canopy won an award from Pilot Health Tech NYC, a Health 2.0 program, to run a pilot with Maimonides Health System, which is the largest healthcare system in Brooklyn, New York. We have found that over-the-phone interpretation did not fit into the medical professional's workflow. There also is a perception that it is inaccurate and that it takes a long time. Some voice that the interpreter felt disconnected or disinterested in the patient. Some feel that the remote nature of phone interpretation impedes the ability for the three parties to truly understand each other. In-person interpretation is a preference for its accuracy and human element. However, it is largely unavailable. To tackle this problem, we have developed a solution with the help of Mount Sinai and Maimonides to build an on-demand, in-person medical interpreter platform to facilitate healthcare providers to be able to connect with both the hospital's internal and external medical interpreters and the institution's bilingual staff. Bill will provide more information on how your institution can get involved with becoming a pilot of Canopy Connect. And of course, you can learn more about this product on our website. And with that, I will hand over the presentation to Bill.
Great. Thank you, Kevin. By the way, at any point during the presentation, feel free to send us any questions or comments you have, and we'll do our best to address them towards the end. So as you can imagine, providing language access to underserved populations is a rather complex and multifaceted issue, and it can be quite daunting when you think about the sheer size and scale of the challenges in terms of the number of individuals who need assistance, the number of languages and dialects that are spoken, and the lack of effective tools and support infrastructure. But there is hope. There are a number of things that we as individuals and as organizations can do. In fact, as Margaret Mead has so eloquently said once, never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has. So in the next few slides, we would like to highlight some of the ways you can get involved, and we also look forward to your suggestions on what we can do together to advance the state of language access. The Canopy Champions Circle is a new initiative that we have recently launched to acknowledge the wonderful efforts that some of our users are already undertaking and to provide logistical support to help them implement the language access projects. From helping with formulating a strategy or plan to creating the content to engage and outreach to their stakeholders, we stand by our champions to help them translate their ideas into action. And thanks to the leadership at AMSA, we have set aside 20 scholarships to make access to the Canopy Learn Medical Spanish course free of charge. So the champions will be, practically speaking, first in line to be awarded these scholarships. And to apply for the Champions Circle, all you have to do is to send us a short write-up or a short video at the email address that's listed on the slide, which is champions@withcanopy.com. So here are several opportunities for getting involved. When you do submit your 200-word write-up or your 3-minute video to propose a language access project, feel free to mention one of these possibilities or propose something that's entirely new. These opportunities are also not listed in any order of preference, and we'll go through each one of them in slightly greater detail on the next few slides. So learning a foreign language is very intense, and it requires a tremendous level of dedication of time and effort. For busy professionals who are also juggling multiple priorities, including medical school or residency, finding the time to learn and practice the foreign language is even more challenging. So as you embark on the journey of learning medical Spanish, for instance, having the support of your peers and fellow learners can make a big difference. As part of our effort to foster a strong and connected community around medical Spanish, we have put together a webpage where you can set your learning objectives in a way that is both concrete and specific, and make it known to your support network. Doing so will also enable us to help you find a language exchange partner who may have set similar goals, who may have a comparable schedule of availability that's complementary to yours, so that we can help you build a community of like-minded partners for your learning journey. So go to canopy.com/pledge and complete this simple process. It should take about a minute or so. We are in the process of reintroducing the National Medical Spanish Month initiative. This is an event that we had done with AMSA a couple of years ago, and we are bringing it back because several of our partners have expressed interest in it, and it's a nice way to give everyone a highly visible milestone to strive for, as well as a shared sense of community and a shared sense of accomplishment. So some of the celebrations that we're considering include featuring success stories of individuals who have achieved their stated learning goals, to publicize the institutions that can serve as role models for rolling out language access measures, whether it's a training curriculum for medical Spanish or a multilingual support initiative for their patients. We may also host medical Spanish practice forums that are moderated by experienced tutors, like the one that you saw earlier in the demo that Kevin had provided. Last but not least, we are exploring the possibility of culminating the National Medical Spanish Month celebration in the form of a world record, such as convening the largest crowd for medical Spanish language exchange, or having the most people engaged in learning medical Spanish within a 24-hour period. We're looking into the application process with the Guinness World Records organization. These are just a few examples, and we welcome your creative and unconventional ideas. Another way you can get involved is to bring Canopy Learn or another learning resource, training resource to your campus or hospital. In addition to individual users who subscribe to Canopy Medical Spanish, we have institutions that license the course on behalf of the employees or the student body or the residency program. In fact, about 1/3 of the medical schools in the country have now leveraged an institutional license to make Canopy Learn broadly available to the students. Starting in 2018, we'll be working with AMSA and our other partners to make these institutional licenses even easier to obtain. For up to 3 institutions that are designated by AMSA as preferred partners, they can be a medical school or a residency program or a hospital or a network of SQHCs, AMSA can offer an institutional license to them at a 20% preferred partnership discount. What we ask in return is to work with these organizations to document a journey of rolling out a comprehensive medical Spanish training program and to publish a case study about their experience. We do anticipate that these discounted licenses will be snatched up rather quickly. So send us a note if your institution might be interested and let us know how you plan to roll it out to your user base. The next example of how one may get involved is on the reimbursement front for language access services. Currently, about 15 states and the District of Columbia allow the use of Medicaid dollars to pay for medical interpreters, whether they are performing interpretation on site or telephonically. However, from our conversations with many language service coordinators and medical billing professionals, very, very few hospitals are actually taking advantage of this funding source. They either don't know how to go about obtaining it, or even if they're aware, they haven't developed the organizational habits and routines to gather the right documentation, or the institutions simply feel that reimbursement is not significant enough in the face of so many other reimbursement incentives and penalties that they have to contend with. In some instances, the unofficial policy was to not encourage the use of interpreters because it's perceived as being quite expensive, even when there are public funding sources to pay for it. We want to find a way to change that. We want to get the hospitals in these states to get on top of this reimbursement opportunity and to demonstrate that it would actually make financial sense to provide language access to their LEP patients or limited English proficient patients. If you have recommendations on how we can go about bringing change in this area, we would like to hear from you. So this brings us back to Canopy Connect, which is a step that we have taken to help hospitals better organize the workflow around their requests for language interpreters and to help them with documentation of their utilization patterns and to provide a basis for their Medicaid claims. While there's a rising demand for interpreters on one hand and very limited supply on the other, what ends up happening is other personnel ends up having to carry the burden of filling the role of medical interpreters. Surveys have found that more than 50% of the hospitals surveyed used ad hoc interpreters. These are family members or friends that the patients have brought in, and nearly 40% of them have used dual role interpreters. They are the staff members who are tapped as interpreters in addition to their primary job duties. Not only does using unofficial interpreters put both the patient and the hospital at risk, the institutions also face considerable opportunity cost in the form of staff time that is lost to serving as interpreters, especially when limited interpreter skills also tended to increase the length of patient encounters. As Kevin has mentioned earlier, Canopy Connect is a platform that empowers all the stakeholders involved, from the bilingual staff to the clinicians who are requesting interpreter assistance, to the administrators and HR or human resources managers. And the benefits to these individuals, as well as to the hospitals that employ them, are multiple, from improved productivity to higher quality and more timely care for the patients, and to being in a better position to capture the utilization data and workflow analytics that they would need to seek reimbursement for the language access offerings. So if you work at an institution or know of an institution that can benefit from this solution and is forward-thinking enough to adopt new and potentially disruptive technology, we would love to hear from you. So in summary, we have looked at about 6 or so ways for people to get involved in the movement to improve access to care for patients with limited English proficiency, and we hope that they would inspire you to think of even more creative, even more fantastic ideas. We look forward to getting a note from you, don't hesitate to mention any of these proposals or any other proposal in your 200-word write-up or your 3-minute video and send it to, again, the email address is champions@withcanopy.com.
And also, feel free to reach out to me, Bruna, and my email is listed on this slide. And do not forget to apply to one of the 20 AMSA Canopy scholarships, a 1-year free access to all 3 levels of Canopy Learn Medical Spanish e-learning system. And we are now dedicating the rest of today's webinar to answering your questions. So please feel free to send them our way. And while you get some time to get on that, I would like to just hand over to Bill some questions that we get often. So what is the price for Canopy Learn, and is there an AMSA discount?
Well, for regular pricing is $495 for all 3 levels of the Canopy Learn course, or $195 per each level. For AMSA members, we offer a 10% discount, so we highly encourage all of you to take advantage.
Also, how does Canopy compare with Rosetta Stone or Duolingo?
That's a good question. Canopy is really in a league of its own. It's highly contextualized for the medical scenarios, whereas other products are more for general purpose learning, and they can be looked upon as cocktail Spanish in some way, whereas Canopy really has a underlying pedagogy and curriculum that's tailored to medical professionals. For instance, we pair up medical themes to linguistic topics in each lesson. We use the lesson on describing a medication regimen to learn about numbers, quantities, and describing steps. And we used the pediatric module on anticipatory guidance to learn about the future tense, for instance. So it's really tailored to the medical professional for their actual workflow on the front line.
Okay, we also got some questions here. If I use Canopy, am I graded? How do I know if I am learning everything that I need to know?
That's a good question. So at the end of each lesson, and there are 12 lessons per level, 36 lessons in total, there is a quiz that you would take to get feedback on your progress. The quiz is tagged and annotated to direct you to certain questions or certain pages and certain videos throughout the course, so that if you feel that you're particularly weak on any topic, you will have a way to go straight back to the point of the lesson where that topic was featured. And then at the end of each of the 3 levels, there's also a cumulative test for you to take to see how well you have mastered the content in that level. And then at the very end, at the summative point at the end of all 3 levels, there's also an exam to help you gauge how well you have mastered the content. And we are in the process of working with an accreditation agency to provide a third-party accreditation for your completion of the test of the course. So in addition to getting a certificate of completion from Canopy, you would also get a third-party endorsed certificate of completion.
Will it also teach me about sentence structure and grammar, or just medical Spanish?
So those are topics that are very much inherent in medical Spanish. So there are 5 or 6 categories of learning objectives: vocabulary, sentence structure and grammar, cultural competency, and so on. So again, when you take the quiz at the end of the lesson, the engine would actually stratify your scores and your performance according to those 5 or 6 domains of learning and be able to direct you back to each of those areas.
Great. If you guys have any other questions you would like us to answer, please feel free to reach out through the emails that I have sent to you in the chat, which are bruna@withcanopy.com and champions@withcanopy.com to apply to the scholarship. Also, 2 more questions. Are there other languages?
Well, the process of filming the videos, the telenovela videos, creating the lessons was very time intensive. So far we've only have been able to do medical Spanish, and we also need to have the demand in order to justify the investment. So unfortunately, we haven't been able to create a comparable course in other languages. We are working on medical English because there's some interest in foreign-born professionals, either international medical students or nurses who are looking for ways to improve the medical English, and they would in turn provide a bilingual competency to help patients navigate the care process. The alternative to a full-blown course such as Canopy Learn is the Canopy Speak app. So that product is currently available in 15 different languages, and the 4,000 plus curated phrases can to some extent fill in the role of some of the more preliminary or more routine conversations. Obviously, it doesn't do as an extensive job as Canopy Learn. One of the new releases we're planning for 2018 is to also make those phrases the basis for learning. We know that a lot of our users for Canopy Speak are already using these phrases to learn how to say it. So we'll be adding a learning component, a game-like experience to the Canopy Speak app so that you can use those phrases as a way to improve your ability to speak those sentences and phrases as well.
And we have another question from Hogan. How long on average would you say it takes for a student to complete a Canopy course and be able to use the information they have learned in practice?
That's a great question. I think it's really more of a case-by-case scenario because students tend to have varying levels of pre-existing Spanish proficiency. Some are heritage speakers, some are second language learners, and also depending on the level of access they're able to engage in. We generally find that individuals who log in on a more consistent basis to go through a level tend to have a higher likelihood of completing the subsequent level 2 and level 3, whereas individuals who tend to log in more sporadically and take a hiatus tend not to complete the full course. I guess the same goes for pretty much all other endeavors in life that are extensive. So we do encourage users to bite the bullet and log in on a more regular, more sustained basis. And in between lessons, you can use the Canopy Speak app to also refresh and also fill in some of the gaps. Now, one of the things we often get asked is how does Canopy Speak or some of our other products compare to Google Translate?
Yeah.
We generally don't encourage people to use Google Translate or any of these real-time translation engines for medical purpose. It's a good reference tool for maybe translating a document, but not so well-suited for live interpretation or live dialogues. There was actually a pretty good article published in the British Medical Journal in 2014 where they compared Google Translate to human translate interpreters. What they did was they took about 10 of the more frequently encountered phrases and had them translated into about 25 or 26 languages, European, Asian, and African languages. And then they send those 250 or 260 phrases to human translators and have them translated back into English. They then took those reverse translated English phrases and compared them back to the original English phrases for accuracy and acceptability, and they found that less than half of those phrases are considered accurate. So the technology is improving, but it's just not there yet, and we believe that a more curated, quality-approved corpus of phrases is a better way to go.
Great, thank you, Bill, and also thank you all for staying with us tonight in this webinar. As I mentioned before, it will be available for download, so please feel free to refer to it should you have any doubts, and also to write to my email, which is bruna@canopy.com, and I'll be happy to help. Thank you all, have a great one, and hope to see you soon.